And if I may, Carol, before you start, just to let people know that Carol is one of the developers of PPOR. So you're hearing from one of the most expert people you could possibly be hearing from on this topic. Oh, and you're muted, Carol.
So that's a little bit exaggerated. I was there at the tail end of the development. Bill was really the key of development. I mean, he was the key analytic expert, but I did help him write it up, and boy, is that a learning experience. so I was involved there, but at the end. Anyway, thank you very much.
I will let you know that we are seeing presenter mode. So
okay, so I have to stop sharing and share again a different way. Thank you.
Yes.
It worked before, Ashley.
I know, it looked great in our test.
All right. I want it to be so that I remember to look in the right place. All right. Now, try this. Does that work better?
Perfect.
Okay. Then I'm looking at the right place. All right. So I'll do this anyway. So I'm Carol Gilbert. I work for City Match, and City Match really was the place where PPOR got developed. There was funding from CDC and March of Dimes, and there was a person named Bill Sappenfield who was an assignee at CDC. I mean, a CDC assignee at City Match at the time. So the agenda is a little packed. I'm sorry. I'm going to talk fast, and I want you guys to stop me whenever you feel like it. And Ashley, you help me to monitor the chat so I don't miss somebody's question. But we're covering a lot. We're covering sort of a general, what is PPOR? What does it bring to the table? Analytic readiness, data quality, which is an important issue for you guys. We're going to go over the homework, so you will have a chance to ask questions. Talk about reference groups, and then phase 2 analysis is the majority. So question, this is the poll question. Have you ever worked on an infant mortality study or project? So Ashley, you can go ahead and share that one when you think, or do I do something?
I will share the results. We have just a few more that I'm waiting on. I can see the numbers. Okay.
So a lot of no's, some participating, and a couple leaders. Okay, that's good. All right. Then we can close that one and go to the next one, which is the more specific one about have you worked on PPOR? And so this is a subset if you've worked on PPOR, and whether you're working on one now is part of the question as well. So mostly knows, which makes sense. And there's some people who are working on it now. So that's great. So let's go on. That helps me to know how much time to spend on what. So initial development, there were, in addition to CDC and City Match, as I mentioned, there were 3 health departments, King County in Seattle, a Boston Health Department, and Hawaii, the state health department, were all very involved. And then after that, there were like 14 more who really contributed a lot. So this was really a community-led effort. There was a lot of angst about what we can do to help do this, to help use our vital records data better. So they were very interested in this and willing to do a lot of work, and they did do a lot of work. So what is PPOR? This is just general stuff. It fits in with a Title V and other community assessments and other stakeholder-driven processes. So it works if you have an existing infant mortality coalition, and I'm going to talk about that more. It works with partner organizations. It works with community members, and I call that members of prioritized communities, trying to be better at that, being more specific about what does community mean. It uses vital records, but it can also use other data sources. And it's really the analysis that you're learning mostly today is really part of a community planning cycle that's bigger than that. So this is how PPOR is organized into that community planning cycle. You do readiness, you do the analysis. In stage 3, you develop your prevention actions based on what you find out in the analysis. In stage 4, you implement them or make the changes that you need. And then you monitor, and you can use PPOR for the monitoring too. Many communities keep on doing PPOR for over and over again. It's just part of the routine. So they can also watch changes happen. Then at the end, this is one really important thing that Magda put in that's different, is that sustaining stakeholder investment. So you really be deliberate about bragging to your stakeholders that you've had some success. And sometimes you can't always attribute everything, as you've seen in the evaluation and presentations that you've had before. You don't always know what caused the success, but toot your horn anyway. And a real reason for you to learn PPOR now is that vital records are really an important data source for MCH, and PPOR helps you figure out vital records, both the strengths and the weaknesses, helps us use it. So specifically, what does PPOR bring to the table? And it brings a solution to this problem. We have these traditional infant mortality rates that we watch and watch and watch, and they go up and down and up and down. We can break them down by race. In the left here, it does that, or we can break them down by period. Neonatal and postnatal is what it shows there. But this doesn't tell us what to do. We need to know what to do. That's why these communities who helped develop it were so interested in developing it. The advantage of the PPOR approach is, one, it's easy to use, easy to understand. It makes full use of vital records data that we already have. We have a small number of events. We need to use the data that we have. A lot of people tend to want to try to do another survey or something like that, and that is hugely expensive, and it doesn't work very well. So use what we have is really an important rule. It helps you identify gaps. It works well to find disparities. It's designed for that. It helps communities target resources, but it also helps them make the case to funders. They may already know what's going on, but if they have some data behind it, it helps them make the case, maybe to get more funding or to get more excitement over some kind of thing that needs to happen. And it does help mobilize the communities themselves. Often communities also are stuck in the place of, this is the way it's been, and this is always how it's going to be. So PPOR also includes fetal deaths. That's a big advantage of PPOR. I don't know if you guys are aware, but there's a lot of fetal deaths. This shows that 33 states have about half of their deaths are fetal deaths. And these are most of the states only report fetal deaths at 20 weeks or more. The states that require reporting of all fetal deaths have about 90% of their deaths that are fetal deaths. That's that top row up there. The 5 states that require reporting of all fetal deaths. And I think I put them in here. Yeah, that's the listing of them. So there's a lot of fetal deaths, and we should use them. Another important thing about PPOR is that it studies 2 major risk dimensions, things we already know are predicting risk. It studies them at the same time, birth weight and age at death at the same time. So that's a helpful innovation. I did that. So another thing, and this is my favorite thing, is it estimates preventable mortality. And this is important because, as you've seen already, excess mortality rates and the number of preventable deaths. But we can't determine preventability from vital records data at the individual case level. So having this method that helps us estimate preventability, granted with some assumptions, is really helpful. So preventability is really important, a guide for what you're going to try to implement, right? You need to know that it can do some good. So preventability is important. And PPOR also helps communities direct their action. So it goes directly from these rates to what you're supposed to do about that. And those things are based on expert opinion, which is always changing. You know, the research changes and improves our understanding. So again, the 6 stages of PPOR are this, and I'm going to start you off with the community and analytic readiness, both of them. So this is the before you go. So what is required? You have to know whether you can do it at all for the community that you're trying to do it for. And you need the vital records data and code books for those data things. And you need the more than 60 deaths. And they have to be the PPOR valid deaths, which you know a little bit about, and we'll talk about that some more. And we recommend not going more than 5 years. Some people have, though. The 5 years is because systems change. And if systems change, you can expect changes. And you know, you don't do a trend analysis when there's things that are changing. I mean, you need a trend analysis when things are changing. And you need an epidemiologist. And I had to update my geek graphic here to a better one. It's a more accurate one these days. This is a change that I've noticed. So these vital records data files, they have, this is where we put in these slides about the 24 weeks and the 500 grams, just to be very clear. For fetal deaths, we exclude the less than 24 weeks and the 500 grams. For the infant, for the live births, we exclude only based on grams. And the infant deaths are a subset of the live births. So they are excluded based on grams only. And it's important to notice that the linked births and infant death files are needed here because we need to find the birth information for the infants who died. They can't be used in PPOR if they don't have that birth weight and gestational age, which comes from the birth certificate. And it's also important that abortions are not included, and there's a lot more abortions than there are deaths, according to several sources. And you know, abortions do represent some health concerns that we might be concerned about, but they're just not in our surveillance system the same way. We don't track where the person lives and all this information about the person. So we can't include them, even though maybe some of them need, you know, they would inform us. We have to go to Guttmacher for that. Community readiness is an important thing. It really, really is. And I'm glad you've been hearing it in a lot of other places besides this. But you can read about community readiness in the PPOR articles. You can find your community partner organizations that already are working on this, working on related issues, and spend some time with them. Listen to what they're doing already and what their concerns are, and then talk together about what PPOR data might bring to the table. It's not really very sensible to spend a lot of time doing this analysis if nobody's going to pick up the ball and run with it, you know, do something with it. So, and a really good place to start is to be listening. Well, we can talk more about that if you have questions. So some communities feel like they're targeted again and again and again. I would like you to consider, as I've been starting to use the word prioritized instead of targeted. And Gabrielle Grode came up with that one. I really liked it. Some communities don't trust the data source, or they might not trust quantitative data in general. And some communities, and often they're right about this, they think they already know what's going on. So why do a study? And one of the answers to that question is, well, you might not really know what's going on. And the second answer is that even if you really do know what's going on, you other people might not believe you as much if you don't have data to bring to it. So now, a really important community partner that may already exist is FEMUR groups. So fetal infant mortality review teams. They have one group that reviews cases, really in-depth reviews of all kinds of medical records, and usually try to include a maternal interview. And then they have another group that takes those conclusions and information that they reach and tries to turn it into action. So that's both the pieces that PPOR needs. And we've done a lot of work with FEMUR teams. They're a very good partner. Don't overlook them if they exist. Child death review can also be helpful. And sometimes those are mixed. I believe in Ohio, it's the same program now, maybe other places too. But there is a special challenge of working with death review teams because they have a difference in perspective. So take a slight detour here. And one of the differences is it's just because deaths are really a small group. They're much smaller than the population at risk, but these teams look at only deaths. The other part is that they're not a random sample or a representative sample of all the births. So they really have people who work with deaths all the time really have a different picture of what's going on in the community. And this is the difference here. Deaths and births are different populations. The prevalence of risk factors is enormously different for deaths and births. So you can tell them this when you're going to work with them. You guys may know a lot about deaths, and they do. They know a lot more about deaths than anybody who works with vital records data. But there are things that you need to know about the whole population, because that's the group that you're going to implement changes for. You need to know about that whole population of births and fetal deaths together. The other problem that you're seeing here is that the reviewed cases do not always reflect the actual deaths. So this is the light blue is the ones we get maternal interviews for. And the reviewed cases, whether it's all or not, we have a lot more reviewed cases than we do maternal interviews. So how is this affecting the lens? And some of the FEMUR teams are not aware of that, and that's something that you can bring to their attention. Your population-based perspective can be important. You guys stop me anytime. I really talk too much, too long, and so feel free to stop me. We're going to move into analysis. Should I stop and let you guys ask questions so far, or is this all really clear? Clear, Nicole. Thumbs up, I see. Okay. So analysis. First is data quality. This is the forgotten analysis step. And we're not going to forget it. So what does it mean? It means three things. All cases, all babies are included. All data items are in each baby's records. The data items were accurately known and correctly reported. So what do you think? They aren't. All the answers to these are no. And missing information really does cause biased results. So you need to know what you're missing and how much there is. So all cases included? No. So reporting practices vary by state, and they don't just vary according to requirements. There are all kinds of practices that vary in addition to the requirements. They don't follow the requirements precisely, and they don't, and there's also cleaning data practice. I could talk about this for a long time. I've been working on this. But so this article is from 2011, and Sharon Ramsey went in New York City and talked to all the hospitals, the chief medical officers, the obstetricians, the neonatologists. I think she interviewed several people in each of the 41 birthing hospitals in New York, and found that, they were just reporting based on what they believed was viability. They weren't concerned at all about the reporting requirements on the state. And I think this is common. I mean, the clinical decisions are so important for the doctors that this sort of administrative stuff, reporting, is just not at the top of their list. And so sometimes PPOR groups have started talking to doctor groups to say, yes, it is important. We need this information. And when you skip stuff, it makes a difference. And sometimes they will change. I think New York has changed a lot and has worked since this on their data quality. This is for fetal deaths. This article was both fetal deaths and infant deaths. So it's pretty clear that early fetal deaths, some early fetal deaths are not included. These are groupings. These different lines in this are different state fetal death reporting requirements. The yellow line is the group that requires reporting of all fetal deaths. That's the 5 states that were in that other chart. The middle 2 green and blue lines require reporting of fetal deaths at 20 or more weeks gestation. And there's some variation. Some of them also require grams. And then the bottom line, which actually has decreased because 2 states have changed their requirements since then. They only base their reporting requirement on grams at birth weight. So fetal deaths less than 20 weeks are not required by all these states under here. But you can see that they start making changes well above the 20 weeks mark. So 24 weeks and above, they're fairly consistent across these groups. But below 20 weeks, the reporting requirements start to change. And as I said before, the reporting practices change even more. So the reason for that 24-week cutoff, it's important. It's important. Otherwise, we would be making comparisons that that really things are measured differently. So it wouldn't be fair. Now this one shows infants, and the biggest problem that we see with infant death reporting is that those deaths below 350 grams, babies do not normally survive. There's just no way that 10% of babies are surviving their first year when they're born at less than 400 grams. So those survivals are very rare events. So what's happening here is that those tiny babies are not being, their deaths are not being tracked. So they got a birth certificate, but they did not get a death certificate. And this, some of this problem is because this is the data that was reported nationally. It is the data that was picked up by the NCHS and put into their data system. And the states are different in terms of how quickly they can do this. So there are some states that are very slow to get those linkages and follow up on those babies that die and find them and put them in the system. So some of them might be better in the state data set that's finalized and that happens much later. So anyway, so the reasons for the cutoffs are that. And I think that we may be able to lower the cutoff for births down to maybe 400 grams, but I'm waiting for some experts to weigh in on that. That shouldn't be just my decision. So the next question, are data elements missing or unknown? And that's easy for us to find out, but we have to be careful. How many of you guys have done things where you subset a sample like this? If they're white and education is 13 years and greater than 20 age, then they're in the group. Otherwise, they're out of the group. The problem with this, that it's fine, it pulls you in a good reference group. This is the reference population. It works for that, but it doesn't work for figuring out who's not defined, who is missing, how many people might be in the reference group or not, and we just don't know. So you can use coding like this to help you capture who's actually missing and who's not. So this defines both the ins and the outs, and whoever's not in or out is an unknown. And this also points out that that it's not that these data quality of all these 3 things, and this is true for anytime something's more than one variable, that the data quality they're dependent on each other. So you need to look at them together to get the real picture. So the other question is about missing data, and this is for imputing. If you have birth weight or gestational age missing, you can impute them from the other. The most common one is missing birth weight for fetal deaths, and you can impute that from the fetal deaths. It's not a very precise imputation, but it's good enough for PPOR. We don't need a precise one. All we need to do is put them in that period of risk. So accuracy of reporting, that's hard to figure out. And there are studies that do that. This is an example of fetal deaths, and they looked at a lot of different education, ethnicity, prenatal care. They were looking generally, comparing the Stillbirth Collaborative Research Networks Registry to the vital records data. And the one on the bottom was looking at births and looking at birth defects, comparing it to the Florida Birth Defects Registries. You always have to have something to compare it to. And another source you can ask for is, I did this once in Nebraska. I asked them for the difference between how the birth certificate saw for causes and how the death review committees looked at the causes, what causes they came up with, and found out that this was a long time ago. And found out that there were a lot of things that were called ill-defined that really were suffocations, and also some suffocations that really were SIDS. And that has since been figured, the CDC figured that out too. I mean, that's common to have that happen. And you can look for implausible values or combinations and check those published studies and ask your vital records department and your child death review people. So there are things you can do, but that's a hard one, the accuracy of the. So another poll. Ashley, did you do the PPOR exercise? So now we're going to go into that review. And next, I'm going to ask you what the questions are, if you have them.
Waiting on a few others.
Siri thinks you're swinging on them.
Okay, here are the results.
So some people didn't do them at all. Hopefully it won't be too hard to watch it while we're doing it here. And there are a few people that have questions, and those are great. You're going to get the chance to ask me the questions. Right now, the question areas is the next poll, and then we'll be able to answer some of them. I'm guessing what the question areas might be, and if I'm wrong, you go ahead and tell me. They don't all have to answer this one. If they didn't do it, they don't have to answer.
We'll give a couple more that I think were there.
So questions about exclusion criteria, selection of the reference group, calculations, and the reasoning and rationale. Good. Okay. So a smattering of everything. All right, let's go on. Can you guys tell me, I did go over some of the reasons for the cutoffs and what those were in the past few slides. If you still have those questions, I wonder if we could bring them up in a session later, in a Q&A session later. But maybe you could do comments or do a chat to Ashley, or put your thumbs up or something. But the other things we'll all be addressing in here.
Katie did make a comment. The slides on the cutoffs were very helpful. Definitely provided context that helped my understanding.
Okay. And I'm willing to go over this some more with people because it's confusing, and it cuts out a lot of babies from the analysis. So it's a serious business, and I'm happy to talk about it more. But I think we should move on because we have a lot to cover. So specific questions, and feel free to chat in any specific questions that are not in those categories. I'm happy to stop and answer those, or you can talk. I don't mind getting interrupted. So this is your exercise. This is Alaska. This is Bill's data. And I did put the article for this in the Teams site so that you could read the article. I didn't do that until this morning. I didn't think about it. And this is just part of what the article was about. So first they sorted the deaths into these boxes, the 4 periods of risk, and these are with the exclusions already. So it's only 500 grams or more for everyone. And also fetal deaths, only the ones that are 24 weeks or more. This is what was left. And this is a statewide analysis, but they did divide it up by race and ethnicity. So the number of deaths adds up to the 265, and the denominator is live births and fetal deaths. Make them into rates by multiplying by 1,000 and dividing by the denominator, just like with IMR. These are sort of comparable to IMR, but they do not match because they include fetal deaths. And they also have these exclusions. And again, the totals sum to the overall. And so this is the mortality rates that are period specific. And then these mortality rates are in the top row. The reference population is in the middle row, and the excess mortality is just by subtracting the middle row from the top row. And the bottom thing is called excess mortality rates, and it's our estimate of preventable mortality rates, preventable mortality. And overall preventable mortality is 2.9. And you could make a pie chart out of this, which you shouldn't do because some of them are negative. And then this breaks it down by race. You go through the same process for each of the race ethnicity groups. And here you can begin to see patterns, like this one on the right for Alaska Natives is much higher in the infant health period than the others. Some other ones are higher as well. But the most important part is the excess mortality. Sometimes those high ones get taken down if the reference group rate is high. So this is excess mortality, and this is where we look at preventability. And again, for this one, it's very consistent. The Alaska Native infant health period is the highest. So we're looking closely at that one. And this is excess mortality rates. I'm going to ask you a question about this later. Then you can go back and calculate excess mortality numbers from the rates by multiplying by the denominator for that population and dividing by 1,000. So the excess rate times the denominator divided by 1,000 gives you an estimated excess number of deaths. The excess number of deaths is sort of easier to put a lot of people who were in the developing of PPOR thought, wow, 24, that's like 24 babies who would grow up and start kindergarten who are not going to. You know, it's really concrete. It's more concrete than rates, and maybe better for a community. And there are other reasons why excess numbers are helpful. I'll show you a little bit about that. This shows overall for the whole state, these excess numbers and how they influence this whole overall excess number of 90, 98. And you can't do that with rates. So and then you can use that city match spreadsheet that's in the resource file to help you do these analyses. Once you've done it once, you don't really need to do it again. It's pretty simple, but I did want to give you a chance to stop and ask questions here. But I'm first going to ask you a question, and that is the question about negative excess mortality, because it can happen to you. What would you tell a community? What does negative excess mortality mean?
Again, you are welcome to unmute or use the chat.
I see there are some chats. Any chats at all about this
Yes,
one?
couple coming in. Negative excess means that group is doing relatively well in comparison to other groups. A second comment, the group you're looking at has fewer deaths than the reference group. Another, that a group has lower excess risk than the reference group.
Yeah, exactly. You guys are getting it. That, yeah. And that's something that the community can understand. So our study group or our priority group in this period of risk is having better outcomes than the reference group outcomes. And it's specifically the reference group that we're comparing to. So that's exactly what it means. And that is a stumbling block sometimes. So good for you to get that through. And then what about this numbers versus rates? Do you see any advantages to one or the other? I talked about this classroom of kindergarten, so that's, but there could be others.
This is Katie. I think generally, oh, somebody just said it, but numbers are easier to communicate. This is just what I was going to say to people who don't necessarily work in this field or who deal with, rates a lot of the time. It's much easier to communicate a kindergarten class than, whatever the rate might have been.
Mhm.
Yes, the IMR rate is confusing to a lot of people. Actual numbers are a lot more straightforward.
Yeah. So I'm going to go back and look at these excess rates. So I agree with what you've said, but I do want to point out that the excess rates sometimes, if the population of Alaska Natives was smaller, the excess numbers would be much smaller than the excess numbers for whites, but the rates would still be higher. And so these rates are helpful if you want to look at the burden on the community specifically. The excess numbers are better about looking for the burden on the whole state. So it adds up to the whole state. So I guess I didn't put that answer in there, but that's the advantages that I would say. So sometimes those excess rates also point to sort of low-hanging fruit. Like these are rates that are much higher for this community. Other communities have it low, and so it really points you in the direction of something that we should be able to change easily. The excess numbers are better for the whole burden and easier for the community to understand. So use both is the answer, but be careful about who you use them with. Most communities don't want to see all these numbers at all, but you need to understand them. So I do want to make sure that you get questions answered about that phase 1 analysis that you did for the exercise. If there are any other questions, now is a good time to check in about those. Because I'm going to go to do more stuff here.
Actually, really quick.
Okay.
This is Sarah. I had actually, like very early on in the calculations, was clearly mixing up 2 of them. So I was wondering if you could kind of walk through that. So going back a couple of slides with the maternal health prematurity versus the maternal care, just
so what the periods of risk mean.
Yeah, so one more slide back, I think. Yeah, here. So I basically had I calculated 63 as the maternal care, not the maternal health prematurity, based on the table 1 in the homework. And so clearly I was mixing something up, but I thought maybe I wasn't the only one. And if you could kind of go over that, that would be helpful.
So for the maternal health prematurity, 63 times 1,000 and divided by this denominator, the 33,406 would give you that rate. And the 57, now there might have been in the exercise, you had to figure out that it was 63. So if that was the issue, do we want to go back to the exercise?
Yeah, that was my issue. And maybe we don't need to go about it now if nobody, but basically I got 63 for the maternal care, not
Okay.
for maternal health and prematurity. So I was obviously reading something
Okay,
wrong.
let me see if I can be smart enough to unshare and then share again. So to show you that exercise, because that you probably wouldn't be the only one. All right. Sorry, it takes me a while. Can you see the right screen now with the numbers? And I might make it bigger.
Yes, I can see that.
Okay. So probably what you did, if most people do this, is with the fetal deaths, you have to take out this whole column, first of all. So that was just put in there for confusion purposes only. No use whatsoever. See if I can sort of cover those up. And then you also take out this whole row. And then you take out the unknowns because you don't know them, don't know where they belong, birth weight wise. And then for the maternal care, you would use fetal deaths that are above 1,500 grams. So I'm going to make those pink. Then the infant deaths, the yellow box is here. Anyway, and then the green box is these. So the only people who are in the blue box is this top row, because it's between 500 and 1,500 grams, and they're fetal deaths, neonatal deaths, and post-neonatal deaths. Is that helpful?
Yes, that is. Thank you.
Okay. Yes, this totally is a tricky exercise, and that's why you have the answer key. I mean, the exercise is just a little bit of torture, but it's really a good way to get it, to get what we're really trying to do and what the exclusion criteria are. So thank you for asking the question. I'll try to unshare and get us back. Okay, so you're seeing the slides again?
Yes, looks great.
Sorry about that. Saying to use the slideshow, interpreting negative. So the two analytic phases. Reviewing the steps of phase 1 analysis. We have the map and the gap. So the map and the gap is what you just did, but the map has really a bunch of steps. So define the study population, restrict those, take out the tiny ones, assess your data quality, calculate the numbers and rates, compare different time periods. We didn't do that so much here, but we did compare subpopulations. And then for the gap, we need a reference population, calculate the excess rates, and identify the excess mortality gaps. That's phase 1 steps. And I'm going to take a little detour here to spend a little more time on the reference groups, because we don't want you to just use the same reference groups all the time. I want you to understand how to make your own. One of the reasons to make your own reference group is that your reporting might be more consistent, and that sometimes a local reference group, if you've got enough numbers to do a good one and your data quality is good enough, a local one can be better, have less differential reporting there. So we want you to choose an easily defined group based on maternal demographic characteristics, not based on health. So we don't do things like take out the smokers or take out the multiple pregnancy results. So this is demographics, and there has to be at least 60 deaths in the reference group. And I say there has to be 150 deaths in the reference group. So I'm a statistician and I just hate it when confidence intervals are so wide, and then you subtract 2 wide confidence intervals and you get a horrible wide confidence interval that tells you nothing. So you want a large reference group. You do not want a tiny reference group, especially if you're going to have tiny study groups as well. And the big one here is that it has to be acceptable to the community. And we'll talk more about that next one. The traditional reference group criteria is the 20 or more years of age, 13 or more years of education, meaning some post-high school education, and non-Hispanic white women. But this let the community choose thing is an important step, and you do have choices. But the thing about the reference group is that it provides a baseline, and it's the best mortality rates that the community feels can be expected, reasonably expected. And that reasonably, this is a value judgment. And it's not just about values, it's also about strategies. But what the reference group does is assume that any rate that exceeds the baseline rate is preventable. So it tells the team which periods of risk and populations have the preventable deaths and where are the gaps. So this really helps communities look at the numbers in a different way. And my question to you now is, have you experienced this thing? And you might not even realize it, but a lot of times people really assume, we really get stuck thinking that the way things are is the way they have to continue. If things are this way, they've always been this way, we just believe that it's going to be that way. And one of the things that the reference group does is kick us out of that spot. Even community members that these numbers are about, they're used to seeing their relatives have very preterm births, say, for example, or they're used to seeing people in the community having SIDS deaths. It's common. They think it's normal. So seeing that a reference group has really achieved different rates can really make a difference in how people think. And that's our goal with the reference groups. If a group really has achieved this, why not? Why haven't the other groups achieved this? And this is not a cherry-picked group that's picked for its health behaviors or anything like that. It's a real population group, and they do pull us into. We do want to use social determinants because those are big, and the best social determinant we have is probably education and vital records data.
Carol,
So
there's a question
good
regarding the reference group.
Thank you.
Criteria, education, criteria, and the idea that if this group can get the rate, others can. I can see age, in parentheses, community can work to decrease teen births, and race, parentheses, community can work to decrease racism and its effect. But I don't think community can make population get some college education.
Oh, yes. So that's a good question. Thank you for bringing it up. Yeah, that's and really education is a proxy for us. It's the best proxy we have for socioeconomic status. You know, if we could measure their wealth or their income, that would be better, probably. Their parents' wealth, their parents' income. But education is not a bad proxy because it does reflect their current earning ability anyway, and it probably reflects their parents' ability. So if their parents had enough money to send them to college, and I know this is a generalization, but it is generally true that parents who are more wealthy can afford to send their kids to college, and so they do pass on that education advantage. But it is just the best proxy we have for socioeconomic status, which, as you've been learning, it definitely socioeconomic status is a big deal. Another very good proxy, if we have the data for it, is zip code or census tract. Since we have such a nicely segregated society, census tracts really do reflect. Oh, Pat's on. She might be going to say something. She's got her hand up too. Okay, good. Go ahead.
You want me to comment on census tract? I also have a question for you, Carol, but I'm happy to comment on census tract. Yeah, I think the importance of considering census tract is that census tract is correlated with individual characteristics, but often it's also different. It provides important information about the context and sometimes some of the structural challenges that communities and individuals are facing. So if you can include information on census tract, that would be kind of up and over the individual characteristics that you're looking at. So I think it would be a great addition.
And
But I also have a
well,
question.
yeah, go ahead and ask your question then.
So, I think in a lot of our work on when we look at race, we're really great at pointing out when we have racial differences, that it's because of discrimination and racism when we're talking about racialized groups. And I think that's true. But we tend to not mention that non-racialized or white groups, as a result of systemic oppression, experience unearned advantages. And I'm just wondering, what role is there to talk about both sides, both unearned advantages and then unearned disadvantages when we're doing PPOR analysis?
I don't know the answer to the question. I mean, I do agree with you that it exists, but what I don't know is that how vital records data can help us with that.
Well, we're talking about why we're choosing, this is a reference group, and the idea is that we would like everybody to achieve that. But I'm wondering if we continue to experience systemic oppression and along the dimensions of race, and some groups get unearned advantages and some get unearned disadvantages, just focusing on the unearned disadvantages, so the discrimination piece, we might not be able to achieve equity overall because of some of the unearned advantages that some groups achieve. So again, just maybe that's food for thought and something to think about.
Mm-hmm. It is something that, I mean, that communities can think about when they choose a reference group. And so if you have things like, if you have a good proportion of your population that can be geocoded, you can do this. But a lot of birth records can't do that. They're the communities that I work with mostly have not been able to do that. But I agree. It's a good idea. I'm not quite sure how to fix it. So the traditional reference group is a little different. In current data, there's two differences between these two. This is the one that was in your example and in Bill's article. And the one on the right is the newer one. And this one is based on states instead of cities. The left one was large counties. So it leaves out rural areas. The one on the right includes rural areas, and that accounts for some of the difference between these. There's another reference group set below here, white versus Black reference groups. And this may get at some of what Pat was asking, that many communities do use Black reference groups. I mean, if you can, you might want to compare your Black population to a Black reference group. And that's something to really give a lot of thought to, and to let your community do a lot of thinking about it. But anyway, you can see that the rates are much different. This is the Black and white rates, as we would expect. I mean, that the Black rates are always higher everywhere, and here the Black reference group rates are also higher. But many states have rates that exceed this 8.9 overall.
Becky shared in the chat, we've had a lot of pushback here when we talk about needing to decrease the IMR for Black residents faster than we decrease the IMR for white residents because of the unearned advantage for white residents.
Yeah. I mean, yeah, it's true. And so if you have a community like that where the Black rate is really, really high and people are saying, there's just no way, we can't do it, it's possible that a Black reference group could help people see Yeah, there are other Black groups that are doing better, and they also have unearned disadvantage. So you may get more traction with using a Black reference group. You know, and traction to get something done, even though the bar wouldn't be as high. It might help your argument more. So it is something to consider, but it is not something to consider all alone as an epi in your office. It's something to talk with your community about, and to talk with all these people here about, all the faculty here together. So I don't know all the answers, but there are some possibilities anyway. And there are quite a few communities who have used different reference groups that are not the standard traditional criteria. And by the way, go ahead.
Another question. So if you need to finish, go ahead.
I was just going to remind to say these are bachelor's degrees, then, so they're higher.
Question on, while data may not be available, but any thoughts on utilizing social determinants of health indicators as a reference group?
So what social determinants of health indicators?
Or SODH is what Jessica,
Yeah, I think she probably means
yeah,
SDOH, but
sorry, SDOH, yes.
yeah. If you can do geocoding, that opens up a lot of possibilities. And that, so what that means is that everybody's address has to be in there. The address of the woman at the time of the baby's birth has to be in there. And if there's any, maybe your state has better social determinants of health than most states, you can do that. It's okay, as long as it's not something that's cherry picking, as long as you meet those reference group guidelines, I would say go for it. If you can do it and the data quality is good. You really have to know about that data quality. So if you have a lot of missing data for whatever the variable is, it will make the reference group rates look a lot lower, because the deaths are always where it's missing. And you don't want to be underestimating your preventability, your reference group, because that'll overestimate your preventability.
And then another question, what is the definition of other Black groups? What does this mean?
Other Black groups? Did I say other Black groups? Like, I'm not sure. You could use the traditional 13 or more years of education for Black. I'm not sure what the question means. Feel free to speak up.
You were mentioning the reference group, and I was just wondering what you meant by using other Black groups. So other than the reference group?
I don't remember saying that. If you were comparing your Black population, you might want to use a Black reference group.
Okay, thank you.
Sorry if I said something I don't remember saying it. Anything else while we're here? Reference groups, I mean, you guys should be concerned about this. This is tricky. And we're making a big assumption here saying that any group should be able to meet this group. So I like it when people think about this and don't just use the one that's in this spreadsheet, in this PowerPoint. So I'm ready to move into some phase 2 stuff, if you guys are. And this is probably all a little more straightforward. Those are kind of the gnarly issues done. But phase 2 analysis takes those gaps that we've defined, that we've discovered, the excess mortality rates and the by period and population. And it asks, what are the likely causes for the gap and what interventions are most likely to work? And there's a bunch of activities we can do to figure those things out. And only one of those activities is this PPOR phase 2 analysis and epidemiological study. Other activities include looking at the scientific evidence. And you guys are the ones who have the expertise to look at and interpret the evidence. Using your community health and health systems assessments that have already been done the CHIPS and the CHAWS. The fetal infant mortality review committees, as I said before, those can be very full of information. And you can also do some research. You can do focus groups to help understand what's going on. You can do anything you want, use any data source you want. PPOR does not stop you from doing things. It just maybe slows you down a little bit because you have to think about quality. So the steps in the epi part of the analysis are first identifying the most important probable cause. So trying to figure out what the biggest causes of death are. Then once you've figured out those causes, you look at the known risk factors, and the PPOR instructions have lists of the risk factors for each of the causes that you figure out. And you look at the prevalence of the causes, the difference between the study and the reference populations in those prevalences. And then once you figured out the most important risk factors, sometimes you can do some more epi analysis to try to figure out the impact, the potential impact of changing the risk factors. First of all, can it be changed at all? Are there interventions that do change? What are their effect sizes? How many people could we reach? That's the kind of thing that you can do with impact, in addition to effect size of your risk factor, adjusted and stuff. So we'll go into that. But the important thing here is that each step depends on the results of the previous step. So it narrows it down for you. You don't have to do everything on all the risk factors and all the causes. You focus on the ones that are important in your community. And I have a picture of a fat crayon here for a reason. We're not trying to do new science. We're not trying to figure out, we're not trying to do research. We're trying to figure out what's going to work best in our community and what's not going to work best. So we're trying to eliminate some factors that we think are not likely to be contributing to the particular problem, the particular gap we see here. And we're trying to find and target factors that are likely to be contributing. We may not know the exact effect sizes. We may not be able to adjust by all the factors we wish for, that we wish we could do, but it's better to look at some of these to eliminate some of the ones that just really are off target and focus in on ones that are probably more on target. So think fat crayon, think it's better than nothing, but it's not precision. What we usually end up with is not precision, especially in small communities. And everybody wants to do a small community. Even if you're a big city, you'll end up wanting to do a small group, like a Healthy Start area, or a small, like immigrants from a particular immigrant community. We want to go as small as we can get. So, because we need to figure out the problems in those areas. So our strategy, again, a factor is a likely contributor if it's known to cause the problem, which is either prematurity or death, usually in the periods of risk, based on the scientific literature, and it's more prevalent in the population that has excess deaths compared to the reference population, ideally. And then you can prioritize after that. So we look for the literature, and we look for what's more prevalent. We can use our standard epi methods. There's a lot of epi methods can be used here. It's a lot of times we don't have enough numbers or enough data quality to do the fancier stuff like logistic regression, and anything below there are usually difficult. And not only are they difficult, but a lot of times they produce nonsensical results, and this is probably because of data quality problems. I've seen them can come up with conclusions like smoking does not cause low birth weight, or it's protective, or things like that. I mean, it's just, this is not what we try first anyway. You don't just come in and do logistic regression and have all the answers. So first, the infant health period. And this is the simplest idea-wise, so it's a good place to start. And there are protocols in the articles, you'll see them, and I'm gonna go through them real quickly here. This is sort of schematic of how phase 1 works and phase 2, the phase 2 steps. So in phase 1, we have figured out that the infant health period is the problem. We do this, what is the major causes? And these are some of the major causes. And we'd like to figure out which is the most important cause in our community. Then once we figured that out, we go on to the risk factors. So this is not a complete list of all the causes and risk factors, but this is a schematic of what's going on in our process. The first step is the causal pathway, the cause. And to do this, this is a frequency table for the causes of death in the infant health period. So this is the babies that died after 27 days, 28 or more days, and they weighed more than 1,500 grams or more at their delivery. So this is a very partial list, but this is typical, like the one cause, one baby, two babies, that kind of, and then you'll see SIDS with a whole bunch of babies. But you'll also see in some communities a lot of W75s, and some communities have a lot of R99s, and those are all part of SUID now. In most CDC publications, those 3 causes of death, W75, R95, and R99, are all considered a sudden, unexpected, or unexplained infant death. And many of those are sleep related, and many of the prevention strategies are the same for those. So we group them. And we also group all the rest of them. This is the grouping that official NCHS uses, and you can find these in CDC Wonder. Birth defects are all Qs, infections are whatever, I's and J's, injuries are W's and V's, and perinatal conditions are P's. And SUID and SIDS, we pull out these three groupings. But in many communities, we end up having very, very small numbers for all these other ones and large numbers for SIDS. And so sometimes it ends up being just SIDS and not SIDS, or SUID and not SUID, I should say. But they have to be grouped. And for each group, you calculate a cause-specific mortality rate. So the number of deaths for that cause divided by the denominator for that period of risk, which is the number of live births greater than or equal to 1,500 grams. You could take away from this the number of babies that died in that yellow box, but it's going to be a tiny, tiny number. It won't really make a difference. Then the excess cause-specific mortality rate just compares your study population's cause-specific mortality rates to the reference group population's cause-specific mortality rates by subtraction, just like in the other steps of PPOR. So that excess cause-specific mortality is what we want to look at. That's the real answer that we've got. And this is an example of how that works. The cause-specific mortality rates are here. A lot of times people just sort of make a pie chart of the numbers and say, look, this is most important. Or oftentimes it's congenital anomalies that are the most important. But if you subtract the reference group rate, things change, and the cause-specific excess mortality rate is the one you want to look at. And that's the one you can make pie charts for. And you'll see I slightly cheated. But the bar chart shows you that the SIDS is the biggest problem. And I didn't get this data, so I don't know if it was really SIDS or if it was the SUID 3 codes. I think it was actually SIDS. And then you can make a pie chart. If you've got negative excess mortality, it's slightly wrong to make a pie chart, but it is, this kind of thing will help your community understand what's going on in that period of risk. And then you take a look at the risk factors for the cause that turns out to be most important. So SIDS risk factors is where we would look now. If we had another one of those come up as important, we would want to look at that too. The risk factors are different. And some of these risk factors that are listed are things that are not available in vital records data. So sometimes we do want to go and look for other data sources. And sometimes we can't always compare our exact group with the exact reference group, but we still want to look at the other data sources and get the risk factor picture that the best risk factor picture that we can. And I want to ask you this question. What about those risk factors that we can't measure? There's a lot of them. And what about the ones that have bad data quality? So we really can't use them. And what should we do at that? I could just give you the answer so we can move along quicker. Maybe I will, so we can make sure and get through everything. But this is really an important question, and it will always happen. There are important risk factors that we don't measure. And one solution is to use qualitative data. But another solution, or the femur results and stuff, and that we put that in later too. But the results-based accountability folks have a good way of trying to look for indicators that you might find in real life. And one of the examples they give in this book is that, if you've got a leaky roof and you're trying to measure whether you've solved the problem, well, you keep a bucket under the leak and catch it. And see if the drips stop coming, you stop doing it. So it doesn't need to be very sophisticated. You can sometimes figure out measures. If women are not trusting their prenatal care providers, you might be able to have use the clinic's quality measures to sort of keep a rough idea on, is this changing or not changing? Go back to this fat crayon idea. And you don't necessarily have to have a huge study to figure out whether you're making a difference. It's important to try to measure things, even if they're not in the vital records data. And you can use all other data sources as well. So that's really a light touch on the infant health period. The most important thing is the cause-specific mortality rate is what you need to use. And a maternal health and prematurity period of risk is very often a large one as well. And this one has a lot of fun stuff in the protocol, in the analysis protocol. The problem with this period is that the causes of these very tiny babies' deaths are complex, and there's a lot of causes. Bill always uses the word cascade. So one thing can happen and then another, and you're not sure which one is going to get reported. And so that the reporting turns out to be not informative. So we have a different method to use instead of using cause of death. What in practice, what I've seen is that they're all P's, they're all perinatal conditions, which makes sense, but it doesn't really help you figure out what to do. So there is something that does help you figure out what to do, and that is Kitagawa analysis. Kitagawa analysis is just an algebraic partition of the excess mortality that you found in your phase 1 analysis to divide it into birth weight distribution and birth weight specific mortality components. So birth weight distribution means how the proportion of babies that are born at each of the different birth weight categories. So we stratify by birth weight. And if you find out that birth weight distribution is the problem, you have to study how many very low birth weight births you have and how many births total. So the population you want to study is everybody, and your outcome is very low birth weight births. The birth weight specific mortality means that there is not good enough survival in the study population, the priority population, among those babies that are born very low birth weight. And for this, you need to study those babies that are born very low birth weight, and the outcome is death or survival of those babies. So which analysis you do and which prevention strategies are very much different depending on which of these the Kitagawa result finds. You want to know which problem you have so your solutions can be related to the problem. Do you need to prevent very low birth weight births, or do you need to focus on getting those babies the care they need to have the same survival rates that the reference population has? You guys stop me if I'm not making any sense. Sometimes I don't. we will do a little more of this, and I'm going to switch over to the Kitagawa worksheet in a second here. So these are a listing of the different risk factors that you would look at for these different things. So if you want to prevent very low birth weight births, you look at things like smoking, race, infections that comes up sometimes, socioeconomic status, birth interval, maternal chronic diseases, parity, and multiple pregnancy too. Yeah, I have that too. Then birth weight specific mortality. It talks about systems of care. How do we get the babies the care they need? Does pay source affect them? Are all the hospitals that these babies are born in using all the right, all the up-to-date methods? Are they doing the best things they can and getting those best things to the right people? This is the Kitagawa formula. It looks a little funny, but it's fine. This is the birth weight specific mortality, the M's are. And if you look at the component of the excess mortality that's related to specific mortality rates, if the reference group mortality and the target group mortality are the same, then this term will be 0 and this term will be 0. And for the whole stratum, this term will be what's important, the proportion of babies that are in that stratum. And again, if the proportions are the same, then the term on the right will go to 0. So that's all the Kitagawa does. It's nice, elegant, lovely. Now I'm going to stop sharing and open the Kitagawa spreadsheet so you can see what it looks like and not be afraid to use it. This is part of the spreadsheet, the PPOR calculation spreadsheet. Okay, so hopefully, I think you see the Kitagawa spreadsheet. What you do is insert your population numbers here, the numbers of live births in the left-hand column, the numbers of infant deaths, and the numbers of fetal deaths. The spreadsheet does the rest. It calculates the denominator, live births plus fetal deaths. It calculates the numerator, fetal and infant deaths. And then it calculates the specific mortality rates. And the specific mortality rates are just the numerator, deaths divided by the births in each row. The population proportion here is the number of the denominator number in this row divided by the total denominator number. And notice we're using the same cutoffs. We're using only, to make our Kitagawa analysis, we're only using the parts that are acceptable in PPOR. We're using those cutoffs. So you can see hardly any babies are born at the 500 to 750 gram range. And most of the babies are born here in the above 2,500 gram range. The gram range for the maternal health and prematurity period is these 4 rows. So this is the part that we're going to look at when we use Kitagawa. This is the part we're most interested in. You have to enter those same numbers down here for the reference group. I wouldn't use this reference group. I'm not even sure what it is. They're just numbers that are in there. The spreadsheet does the calculations and gives you a nice pie chart. And this is a typical pie chart for a community that has white people in it. The pie chart for communities that are only Black usually have much more of almost all of the thing or all of it being due to birth weight distribution. I think that you can figure this out easily by looking at that and it's really not hard. It looks like a mess, but it's not at all. So just try it. Try it yourself. It's not bad. The important thing here is that we want to look at the top rows. You add up these top rows to get this number, and then those are the percentages that are in the pie chart. You guys can interrupt me. Any questions in the chat? Anything at all?
I don't see anyone or any at the moment.
So the formula, we're done with Kitagawa. And what you do once you do the Kitagawa, you do the risk factors that were listed in that tabulation. And again, you compare prevalence of the risk factors between the study population and the reference population. And this is just one little example of that. Nothing, it's not rocket science. It's also a good idea to look at your FEMA results. A lot of communities have looked at their FEMA results in the context of the periods of risk. So you can go back in time for FEMA data that's already collected and just put them in the periods of risk. And although this may not mean a lot to you guys and to me, because like I'm not a neonatologist, you will have experts on your committee who this means a lot to. So this data can help them interpret what they're seeing in the vital records data. It goes way beyond the vital records data. So a question for you, and maybe we can just not do this as a poll because I'm taking too long to talk. But I said back there that fetal deaths were optional, and I wanted you to argue with me if you want to. I can go back to that spot. Fetal deaths are optional if you're talking about birth weight distribution. A lot of people ask this when you get to it, because for all of our PPOR, we've been including fetal deaths, and that's important. When your denominator is all births, fetal deaths are very small compared to that. And so you can add fetal deaths, and theoretically you should, but it won't make a big difference because there are not as many of them. And it causes you a lot of trouble because of the data quality issues in fetal deaths. There's a lot of data elements that are not reported in fetal deaths at all. The states just don't do it. And then there are a lot of elements that are not reported as well. And so you'll introduce some bias and it might not be worth adding. But if you want to give it a try, theoretically you should include all fetal deaths. Less than 1% in data quality problems. So using regression can be helpful. I said before that the numbers get small and most communities don't end up using regression. I think that the way I was taught how do you do regression, logistic regression, the part about preparing for it is just as important. You go through each variable separately, then you go do two-way tables for each variable, three-way tables. You look at these relationships between the dependent variable and what you're trying to your independent variables that are important. This gives you a chance to look at things like effect modification and interaction, which can be really important as when you're looking for what factors are important. So it might be worth it to go through some of those steps, even if you don't have the data quality to do a full logistic regression. It will help you figure out some of these things that if you don't go through those steps, you won't. And then the adjustment is helpful, and just the simple p-values that you end up, even if you don't have a very complicated model, it gives you a confidence interval or a p-value, and that can help you exclude factors that are not important. So these can be helpful. Just use them carefully, just the way you were taught in school when you learned regression. So this is an example of what you can see. Not so much the variables that are important, but the confidence intervals. So this one, whites versus non-whites in the Hispanic population, no big difference. Confidence interval doesn't show significance. But blacks versus white among the non-Hispanics is a big difference. So this helps clarify which things are important and which are not. Just having the confidence interval. Then this is one where it looks at risk factors by race. Stratifying by race is helpful, or stratifying by any of your, socioeconomic status could also be helpful because they're different. The different factors come up and different odds ratios come up, and this helps you get a picture of what things are important in some places and not in other places. Inadequate health care does not come up for white non-Hispanics, for example, in this thing. It's protected for African Americans. See that there's some strange things that come up. Population attributable risk, I think, is helpful. And EPIs tend to think that population attributable risk is for estimating impact, and that you have to adjust it, and you have to get you have to use it to figure out effect size, and that's not what I would use it for. So I'm going to show it to you anyway, but it's just based on a 2x2 table, and this is so you can see what the formulas are. Then the formula that's most useful is this one. They're all the same, but this one is the most useful form because you can use relative risks that are adjusted if you have them from your own data or from studies. And the interpretation is what's important. What they literally mean is that if the women who were unmarried in that example that I showed you above, if the women who were unmarried could all have the same low risk as the women who were married, we would reduce the very low birth weight rate by 19%. That's what it really means. But they're in real life, of course, the unmarried women have other risk factors that won't go away if they get married. So this is not a cause statement that we could say, marry them and they'll have low birth weight. But it is sort of a measure of the impact of marital status, that it may be, so 20% is a big chunk. What's going on here? And it's usually an upper bound, because if you adjust it, it might decrease it. So it helps you rank the importance of risk factors based on both the prevalence and the severity. Now, we may want to rank the importance of risk factors based only on severity, and that's fine. That's fine too, but prevalence is like the burden on the society, so you might want to also look at that. So this is an example of often we get prevalence tables and we get risk ratio tables, but sometimes adding this third column with the population attributable risk will make it more clear which things are important and which things the community might want to focus on. And the only thing that's different in this particular example is, say, the not married and the women over 30 have the same risk ratio, but they have different PARs. So one of them is higher than the other. So this might help the community decide, well, maybe not married is a more of a thing to look at than being over 30.
And a comment on that, Kathy shared marital status in this case may be more of a proxy for SES and insurance healthcare access. And
that is a really good point. Marital status is different in different places, what it means. It really doesn't always mean what you would think it means at all. Sometimes it means that people are not putting the fathers on the birth certificate because there's some, there's some motivation not to do it. Sometimes it doesn't reflect reality at all. So marital status and father on the birth certificate is another one to look at if you've got good data quality for that, which some places are beginning to get that. So yes, it's not straightforward what that means at all. And I would involve the community on interpreting factors like this, because vital records data is limited. And if you have a femur and femur teams can help you with that perspective, that might be helpful too. Yeah, it's not at all clear what that means across the nation. Marital status isn't very helpful, but you can investigate that at the local level and figure out what it really means, maybe better than we can just looking at vital records data.
And Pat commented, since we know that structural determinants are the root causes of inequities, I wonder if you have some good examples of PPOR that has used or incorporated data on the structural determinants of health as risk or preventative factors. It would seem an important strategy to use if PPOR is to ensure that we begin to make changes to inequities.
That's a very good idea. I would love to work with you on that. we can write up some protocols. And I don't know of communities that have really done that. I mean, we could talk more, but I agree with you. The maternal care period, we want to have a little bit of time to go over the protocol for that. This is the larger stillbirths, babies that are delivered at greater than 1,500 grams, but they're fetal deaths. And we have some challenges here. As I mentioned before, the stillbirth, the fetal death records are poor data quality, and there are differences from state to state as far as what counts as a stillbirth. And they're not just state differences, they're even hospital and doctor differences. So they show up at county level too, and within county. And many stillbirths don't get counted at all on purpose and not on purpose. So the cause of death is really difficult to determine, and it's not consistently reported. So with all that taken into account, we kind of recommend, I mean, there's really not much choice about this at this point, is skipping the step about determining the predominant cause and going right to this step about prevalence of the known risk factors. There are some known risk factors. There's been some good research fairly recently in the last decade about stillbirths using the Stillbirth Collaborative Research Network. They did and I think they're still collecting data. They have 5 states, I think, that collect very thorough stillbirth information. So there is some more information coming out, but the risk factors is still probably the best place to start. BMI is a big one for stillbirth, as is advanced maternal age, and also advanced maternal age if it's your first pregnancy. But stillbirths are still something of a mystery. We have had communities do things like try to identify women who've had a previous stillbirth, because this is likely to be repeated, and they can work on the structures around, what's encouraging those women to get back into prenatal care early. Is their birth spacing adequate to get resolved whatever the health issues are? Those are the kind of structural issues that communities have dealt with stillbirths. There's a list of risk factors that are fairly reliably collected on death certificates, at least in some states. Have to check this, and it's very hard to tell again whether they're collected correctly. You can tell if they're there or not, at least. And then there's also some other data sources that can be helpful. BMI, you can get that from PRAMs or from BRFIS data, for example. And the weight gain during pregnancy adjusted for BMI is a good one, because weight gain is also an issue, and it's probably related to diabetes and hypertension. And you can also, again, use your femur data. A lot of communities that have big excess mortality in that maternal care period of risk focus femur reviews on the larger stillbirths for a time in order to get a better picture of what's going on. but it's not easy to do really high quality studies on stillbirths. And I did want to cover just quickly, this is the very last bit, but if you want to do some of these analyses that really have an outcome and independent variables, you need a birth cohort. And to do that, you need to make the birth cohort if you haven't got that. You might be able to just request it. States do make those. But if you haven't got the birth cohort, if you've got the period files like what we've been using, where they're the same year for both, you need to put them together in order to get the right file. So you use, this is just a little quick overview of how you do that. How did I do that? You have to take the live births and then get some of those are deaths. You link the death certificates to those. I mean, they're already linked, but you have to make sure that you know which ones those are in your live birth file. And then you stack the fetal deaths onto those for a year. In a little more detail here, you have 2 years of data from the 2000 year and the 2001 year. You put those together and you keep the ones that are born in 2000 and follow them until they die, which means you have to follow them through the following year, because some of them would be born at the end of 2000. So if they died before the end of 2001, they would be deaths for your study. So you end up throwing away a year to be able to get that. And you can do that for each of your years. But that gets a little messy. And then just to quickly go over that there are other data sources that you can pull in to use PPOR. This phase 2 analysis, being as open as it is, allows you to pull in stuff. And even neighborhood level data like PATS, the context, the policy context, you might be able to pull data in like that will help you. So it doesn't leave anything out. And that's the end. I don't have all the answers, but I have a lot of like geeky little processes. And I'd be happy to work with any of you guys who want to do an analysis. I do this all the time. A lot of times people are kind of on their own with this, and just having another person to say, wait, does this make sense, can be helpful. And so I encourage you, if you are doing a project like this and you find yourself standing still or like being very confused for a minute, sometimes just a quick phone call can get you out of that spot and pushed ahead into some better results. So I encourage you to contact me at this email, and we can just organize a little call. And there are some meetup times listed in the appointment schedule for this class too. And that's all I've got. I'd be happy to argue some more, especially with Pat. She's full of good ideas.
Thank you, Carol. And again, you're free to unmute, utilize the chat, ask questions, comments. A question from Maria: has the PPOR framework been adapted for maternal death data?
No, it hasn't. And that would be very difficult because of the small numbers of maternal deaths at the local level. It might be possible to look at maternal near misses. The birth file has some maternal birth, the information about the birth. Right now, the maternal morbidity and the near miss data comes from hospital records, which we don't normally have access to. But if you do have access to, you can do that sort of thing. And you would have to invent the periods, though. The risk periods are invented based on that cluster analysis. They have causes that are similar. So we would have to do some research too. We couldn't just use the periods of risk that PPOR uses. I think they wouldn't make sense. But it is possible to use the concept of a reference group, and it is possible to use local level data. So some of these ideas could be transferred to that.
Maria said, thank you.
Welcome.
Any other questions, comments, experiences with PPOR?
I have a question.
I can never answer your questions, but I love them anyway.
I've never had the opportunity to do PPOR. I'm sorry to say, but is this ever done in sort of a community-based participatory way where you create teams that include the community and maybe members of the community from the groups who might be doing the worst, so that they can really weigh in, and they might be the groups who you have the least data on, for example, so that they can kind of weigh in from their own perspectives what might be happening. And I kind of asked that because in the health equity group, we had talked about how affected communities can provide a very different perspective than, say, service providers because of their lived experience. So I'm just wondering, to what extent can you use participatory action or partnered approach to doing this work?
Yeah, I think it does work well. And City Match does this, works very hard at this. The groups that we coach in the Equity Institute and other ones, we make it a requirement that they do include community members. And we also sort of try to help them really include the community members, which is not so easy. But that is something that the City Match staff is very familiar with. I wouldn't say that it always happens, but it is a goal. And when it happens, PPOR is understandable to the community. They are willing to get in there and debate these things. What does marriage mean in your community? And they have ideas about these things and can be very helpful. I would say we don't usually, I have done this, and it just puts you to sleep, like these people that, like you all right now, are asleep. But I mean, they don't need to see a lot of data. They don't need to see exactly how you do the calculations. I think they do need to see where those numbers come from, who fills out those forms. Like they need to know that kind of thing. And they need to know what it's good for and what it's not good for. Like they will, it's important to be honest about the weaknesses of the data source. You're going to use this data source, and you don't want to tell them it's all weaknesses, and but you do want to be honest about them. But you wanted to, and we don't want people just throwing it out because there are weaknesses, and we don't want to do that ourselves. They still can, even though the data is not perfect, it can help steer you in a better direction. We've had a lot of communities where doctors have been in charge of these things, and they tend to think in terms of the big issues like congenital anomalies, and they can't let go of those, or shaken baby syndrome. That's been one that people hear about that in the news, and so they think that's a big deal. So seeing the population-based data like this can steer them away from those things that are kind of dumb. They're not dumb, but they're uninformed. and it can steer us toward things that are important. So
I think that's where theory would be important too. I mean, again, in the health equity group, we heard about how, maternal mortality reviews or fetal mortality reviews tend to be dominated by medical types. And they, of course, have a biomedical perspective on the causes of these deaths, and don't really have a full appreciation for the social determinants. And so if there was a way in which, PPOR had a real strong social determinants perspective, it might be able to guide and weight some of the data that should be part of the discussion about prevention and reducing inequities.
And that is why PPOR does steer people towards social determinants, because we've got that education in the reference group. That is a non-medical thing, educational attainment. And race is a non-medical thing. Age doesn't make a lot of difference, but since we're having these social things in the reference group, it points us right away to social determinants. How to get it better? I think there's better ways, probably. I really ask people, especially if they've got bad data quality for education, can we get something out of the mom's addresses and use that information? But we're really limited for at least the first stages and the reference group thing to what's in the vital records data. So yeah, it would be nice to figure out ways to make it better. I can see that you're already thinking of that.
Well, I'm just wondering, so we love to talk about the social, and I don't mean to monopolize. I want to leave time for others. Maybe I'll just say this really small thing. We love to talk about the social determinants of health, and I love to talk about the social determinants of health, but so many of the social determinants are really political determinants of health, which make them hard to engage with groups who feel threatened by some of the conclusions that we draw when we study the social determinants of health. Mm-hmm. And we tend to, I think, sadly, shy away from a description about what is happening politically. I'm a US citizen and I care about what's happening, but I'm kind of watching from a distance and seeing what's happening. For example, you talked about education, how there's this movement toward barring critical race theory. Not that it's actually taught in elementary schools, but there's this movement towards barring critical race theory because it is a threat, or perceived threat, I should say. It's not an actual threat. And, there's this movement about criminalizing protests of individuals who want to advocate for their own improvement. And so these are political issues which in fact do keep progress from being made. And I think they should be part of the discussion.
Mm-hmm. Yeah, they should be.
But that could be part of when we talk about race, what do we mean? It goes beyond just, we mean racism. I think we have to talk broadly about what that means even historically, right? Because these are recurring themes over and over again from the time of slavery.
Mm-hmm. And you wouldn't have those discussions if you were using only stakeholders. People who get paid for their work on these teams are not going to have those discussions, I think. I mean, that's what I've experienced. But when you bring community members in, you can start to have those real discussions. So that is one of the reasons that City Match pushes for that, but doesn't always succeed. One political thing that's in the data that we could measure is the Medicaid and Medicaid's effect on like getting good care after the pregnancy, birth spacing, that kind of thing. You can get some of that.
Yeah, agreed. Thank you, Carol.
Thank you. Thank all of you.
There is a question about Kitagawa analysis specifically, and why is the focus on very low birth weight instead of very preterm?
Oh, that's a good question. I I think the answer is from the point of view of the people who developed PPOR, because birth weight is much more precisely measured than gestational age, especially at that time. It was before the before ultrasound was a big thing, and now gestational age is getting a little better. And that may be one of the things that we do when we improve PPOR, if we ever get around to, is switching over to gestational age. It's a possibility, especially for fetal deaths. It's better measured than birth weight is.
But it is still missing on more records than low birth weight, than birth weight.
For fetal deaths, there's 50% of fetal deaths are missing birth weight. But of course, they're the tiny ones. Most of those are the small ones.
Got it.
And it's not likely to improve because you can't measure it very well on the tiniest fetal deaths. But yeah, it's really, but there is missing on both sides. So I did look at that, but right now the data quality isn't so that you could really do that, because you'd end up having to impute from birth weight anyway, and then you've got birth weight again. So I'm not really sure what the answer should be, but it's a good question. Gestational age is really kind of, it's important health-wise, you know, it may be a better measure,
And Carol, I'll just add, as you're alluding to, Kitagawa analysis is just a statistical analysis method, right? There's nothing that ties it to using birth weight, right? It's just a statistical method that decomposes these rates into a distributional component and a risk factor specific component. And so you could do a Kitagawa analysis with gestational age instead of birth weight. As you're saying, as you're alluding to when you say that you might change the recommendation, but anybody that's doing a Kitagawa analysis for your own jurisdiction, if you think that very preterm makes more sense, I think that you could use the tools to do it that way.
But right, if you've done your phase 1 analysis, your blue box won't match up then to the Kitagawa analysis results. But
yeah, that's true. That's true.
you'd have to redo
because
the
that's
blue
based
box.
on birth weight.
Still, you can do it. You can do it for all kinds of factors, not just for birth weight or gestational age. It's a good thing. And there are better ones too. There's better decomposition analysis, which I haven't even tried yet, but I've learned about them.
Any other final questions or points of discussion for Carol? All right, Carol, thank you so much for taking the time to present about this and to share your expertise with this group. If you're going to do a PPOR analysis, as Carol mentioned, she does a lot of consulting with groups across the country who are doing this, and she is just excellent at that. She's, I don't know, she's Carol. I know it's uncomfortable to have somebody talk about you when you're right there, but she has so much expertise, and she's really, really good at helping teams, even if they're not super data savvy, through these things that seem complex, and she makes them really easy. So utilize the technical assistance that you have access to. I also want to say, as we get ready to sign off, we have some great sessions coming up on Wednesday and Friday. Dr. Michael Kramer will be presenting in those sessions about some more applied statistical methods. So that's exciting. I also posted a couple of things on Teams in the YouTube recordings module, or I don't know what the best thing to call those tabs is on Teams, but a couple of weeks ago when I was doing that overview presentation, I was kind of talking bad about odds ratios, and people are interested in knowing more. So I recorded I was about to say quick, it's not super quick, but a video about odds ratios. And as I posted in Teams, I tried to be unbiased. It's titled Down with the Odds Ratio. So I'm not unbiased. But Michael is also going to talk and share some about his perspectives on this too, because I think it's useful to hear multiple perspectives on an issue like that. Also, I posted a series of recordings on trend analysis. So if that's a topic that you're interested in, all this stuff that's being posted there is optional. So feel free to take it or leave it. So just wanted to make sure that you're aware of that. All right. Thank you. I'll be quiet and let Ashley close us out.
Thanks, Mike, and thanks everyone for joining us. And one note I just wanted to bring to your attention is there is a homework exercise that Dr. Kramer is asking for you all to complete. I'll share more in the email probably today, this evening, so you have a full day to get to it. There is a form submission similar to Dr. Sappenfield's, so just a quick way to gather responses and then be able to utilize that in the live training session. So again, you'll get an email with the recording and evaluation, and we thank you for being here, and we'll see you again on Wednesday. Thanks, everyone.